I mean, another surgery. I just had one, you know, they're both happening within 2 weeks. Just to clarify something, some of y'all have asked about this shirt. It says corporate 5K on it. I did not run a 5K. This is my mother-in-law Anne's shirt, and I just like to wear it because it's comfy and it reminds me of her. But anyways, I mentioned a few days ago that my surgeon and I created a plan in regards to my port, because if you've been following the past few weeks, my port has been malfunctioning. The first problem is that it started to invert or flip, and it's painful because it's not in place anymore, and it becomes very difficult to access. And the more it flips, the more unusable it becomes. And this can happen to anyone with a port, but I'm more at risk for it because of my Ehlers-Danlos syndrome. Then I was in my surgeon's office and she asked me to deaccess so she could look at the port. And the skin on top of the port is ulcerating, or it's dying. Now, the skin is dying because there is always a needle in it. And although I try and alter slightly exactly where the needle goes in, there's always a needle there. And that means there's no chance for the skin to heal. And with my poor healing from my EDS anyways, it's kind of a recipe for problems. Now, from what my medical team has told me, and if your situation is different, totally okay. This is my personal experience, but they have said ports are not really meant to be used 24/7. They are meant to be accessed for treatment and then deaccessed, so there's no needle in it. That's the ideal way to use it. When you use it 24/7, there's always a needle in it, then it shortens the lifespan of the port. When I first had my port placed, I was using it intermittently, specifically for my treatment, which at the time was only IV fluid infusion. So I'd access for the infusion, deaccess, and that's it. And I would only do that once or twice a week. However, my needs have changed. I need more IV therapies, and because I'm using my port multiple times a day, I am accessed 24/7. In turn, that has shortened the life of my port, and it is a problem now because my port constantly hurts me since it's flipping, and the dying skin, that's an issue as well. And instead of lasting several years like it could have, it's not even made it 2. December 5th would mark my 2-year portiversary. And my surgeon and I have discussed this to no end. We've been very thorough about all of our options, and we think the best choice is to remove my port. I am not happy about this, but the stress of my port not working properly, and not only that, but getting worse, was overwhelming, because quite honestly, my central line is my lifeline. And so when my surgeon told me we needed to remove it, part of me was scared, but mostly relieved, because we were gonna fix this big problem I'm having. But of course, removing my port takes away my vascular access. I need other options for vascular access, and we had a very long and several discussions about what would be the best option for me. PICC lines, Hickman's, another port, what? And we came to the conclusion that an AV fistula would be my best bet. So what is an AV fistula? Because I didn't know before my surgeon brought it up. Basically, it's a very big, strong vein. So what's gonna happen is my surgeon will do a surgery where she connects an artery to a vein. And the extra blood pressure and blood flow from the artery makes the vein very big and strong. These are most often seen with dialysis patients, but ports are commonly seen with chemo patients, and I'm using it for another reason. The AV fistula can be used for another reason as well. The reason I like the AV fistula is because the infection risk is substantially lower than another type of implanted device. With a port, there's a catheter running to my heart. With a PICC catheter, Hickman catheter, that is what creates the high infection risk. With the fistula, it's my own body. There's no device inside me. The only thing that will be there is a peripheral IV, which will be able to find the vein, and it won't blow the vein because it's a big, strong vein. So the infection risk is equal to that of a peripheral IV, which is much lower than another type of midline or central line. I also like the fistula because, as I mentioned, we'll be able to find it and it won't blow because it's a big, strong vein. It's a big target. Fistulas also typically have very long lifespans, and they can sustain a lot of sticks. And if we needed to, we can leave the peripheral IV in for several days at a time until it needs to be changed. I think my surgeon said about 5 days. The things I don't really like is that it's in my arm. I prefer things in my chest, but you know, I'll deal with it. Also, I'm not sure if I'll be able to access it myself because I'd have to do it one-handed. My surgeon says people do it, but I'm not too confident about that. However, my home health nurse can do it, and we're also going to teach Judd because Judd knows how to access my port. He's gonna know how to access my fistula, and the fistula should be easier because peripheral IV and a big, strong target. Another thing I don't think I'm gonna like is how it looks. It's gonna be a beefed up vein. Right here, it's gonna look like a worm under my arm, but it's not going to move. However, it's more of a vanity thing. I know I'll get over it because it's really gonna help with my IV treatments. Also, they can be placed down here, but I prefer it to be up here, so that's what my surgeon's gonna do. I think the fistula is going to give me a lot of freedom because with the port, it's accessed. I use it frequently, and the highest point of infection risk with a port is when you're accessing it. So I access it as little as possible to cut down on that infection risk, which is once a week. So it's always accessed other than when I'm taking out the needle and putting it back in once a week. The fistula, there's a lower infection risk and it can handle a lot of sticks. So I think I'm gonna have more freedom to de-access it when I'm not using it. And I'm working really hard to cut down on the amount of IV therapy I need. I'm doing great with the Xolair, so I'm hoping to cut down on reactions that require quick IV Benadryl. Plus, accessing this is gonna be quicker than a port because it's just peripheral IV. But anyways, for example, I'm trying to cut down on my IV therapies. At the beginning of the year, I needed 6 liters of fluids a week to function. Now, I'm at 3 or 4, sometimes 5. So maybe not a big difference, but I'm making progress on cutting back. However, I really wish I would have gotten the fistula sooner because when she does the surgery, it's gonna take several weeks, up to 2 or 3 months, for the fistula to form and be ready to use. My port is not going to last that long. So we had to think of something to use in the meantime because I can't just stop my IV therapies for that amount of time. We talked about all the options and we decided that placing another port in my left side would be the best choice because we can leave it de-accessed if I'm not using it and I'm using the fistula. And when I have the fistula, I'll still have the port if I need it. And then eventually, if I go a long time without needing the port and solely relying on the fistula, we can remove the port. But the fact that I can use it if I need it, and if I'm not using it, we can just de-access and not worry about it, that's why we think it's the best choice. So on the 24th, I am going to be getting a fistula placed, removing this port, and putting in a new one. To make sure my new port doesn't have the same problems as this one, my surgeon is going to suture it in place. So it's unlikely to move or invert or flip. And then if you're worried about the skin ulcerating like it is on this one, that takes time. My new port will only be accessed 24/7 for 2 to 3 months tops while the fistula is forming. After that, we can de-access it and rely on the fistula and use this intermittently if needed. So my new port will not have the same problems as the old one. Now, while we have thoroughly discussed everything and everyone involved is confident in the choices we've made, I'm still concerned about the surgery. You know, everything separately is not that big a deal, but taking this port out, putting a new one in, putting in a fistula, that is quite a bit of stress to put on my body. And I'm still not doing all that well from my previous surgery last week. Also, we have to run a preoperative IV antibiotic to hopefully prevent infection, specifically MRSA. And we've been using IV daptomycin because while I have bad side effects with it, I don't automatically have anaphylaxis like I do with many other antibiotics. But my side effects to the daptomycin are increasingly worse each time I get it. So my surgeon is concerned that we're kind of setting me up for failure by giving that to me. So there's another antibiotic, IV clindamycin, which would be suitable, but I've never had it before. So we don't know how it's going to affect me. And we've consulted my immunologist on this because it's really my mast cell disease that's giving us the issues with the antibiotic. And since we know that the daptomycin has bad effects and it's getting worse each time I get it. She feels it's worth the risk of trying the clindamycin. So hopefully it won't give me that many issues. And if it does, I'm already in the hospital. It's frustrating, but not running the preoperative antibiotic and putting me at more of a risk for infection, especially MRSA, not worth it. So we're gonna run it. We're gonna pre-medicate me. Hopefully all goes well. And depending on how things go, I may need to stay the night, but my surgeon said, you know, pack as if you're gonna stay the night, but if you're doing okay, I don't have to be admitted. And this is also why we're doing all 3 procedures at the same time. It is a bit of stress to put on my body, but that means we only have to run the antibiotic 1 time and do anesthesia 1 time. That's 2. I meant 1. You guys know what I'm talking about. So that's the plan. I know this may come as surprising information for y'all, but I wasn't ready to share it quite yet because I don't know if sensitive subject is the right terminology, but it was just a big decision and I wanted to make it myself with my husband and my doctor and, you know, my mom. I didn't want outside influences. You know, I needed to come to this conclusion myself and be confident about it. And I am, you know, I think this is the right choice. I just didn't choose to share it with y'all sooner because, like I said, I needed to be confident in the choices and come to it myself. And so next week is when the surgery is happening. And I think the surgery itself is the most stressful part, but after that, I think my vascular access will be better and less stressful. You know, I won't be having the problems I'm having now. I mean, another surgery, I just had one, you know, they're both happening within 2 weeks, but this really can't wait. You know, we need to fix this sooner rather than later. The one on my foot really couldn't wait, so it's kind of just how things have timed out, but it is what it is. I have a dedicated medical team. I have supportive friends and family. I have Harlow. I have God walking with me on this, and I have y'all cheering me on, and I really appreciate support. You know, it's the right thing to do. It's just getting through the surgery, and next week should be interesting, but I got this. Keep moving forward. And with that, I will say goodbye, and thanks for joining us on our adventure.